Welcome to another episode of the CNS Controversies and Neurosurgery Podcast. My co-host, Dr. Seth Oliveria, and I, Rushna Ali, are excited to hear our guest speaker, Dr. Ryan Ormond, who's an associate professor of neurosurgery at the University of Colorado, talk about the nuances and controversies associated with awake versus asleep mapping for tumors. Welcome, Dr. Ormond. We'll kick things off by asking you, a question that a lot of trainees have, even those who are actively engaged in clinical practice, is, what are the characteristics that make a patient a good versus a poor candidate for awake mapping?
Yeah, so that's an interesting question. I think what's interesting is if you do this for a while, you just kind of meet a patient for about 5 minutes, and you typically know if they're going to be an easy or a very difficult patient for an awake operation. So there's some nuance, obviously, to all this, but I think there are some challenges, right, with awake surgery. And I think patients with strong mental health histories of especially anxiety disorders, claustrophobia, and or PTSD, and some of those, as well as substance use disorders, tend to struggle more in an awake setting. Obviously, younger patients with a language barrier that can't be accommodated well for in the operating room, patients with speech deficits or other cognitive deficits, impulsive patients, for example. I mean, these are all patients that are not complete contraindications necessarily for awake surgery, but ones that present challenges and sometimes make it impossible to proceed or to successfully get through an awake operation.
And again, this is Seth Oliveria, and thank you, Dr. Ormond, for being here. And so maybe just to back up just a little bit, so kind of for some of our more kind of junior trainees who might be listening, why might you want to do an awake surgery?
Right. So, when we think about structure and function in the brain, non-invasive imaging does give us some understanding of what's going on from a functional perspective, but it's all secondary information, right? So if we're looking at a bold signal, it's helpful, but it's not perfect, and it's based on normal subjects, right? So if you have someone with any pathology, tumor or otherwise, that alters the brain anatomy and likely its physiology as well, and can distort the signal, whether we're talking about diffusion tensor imaging, the bold signal, right, in MRI. Even vascular signals can sometimes be different. And so it can be a challenge in a non-invasive fashion outside the OR to understand anatomy and physiology perfectly. And now we're talking about invasive procedures into the brain, whether they be functional procedures or tumor resections, especially in the case of diffuse glioma, let's say, where tumor is intermixed typically with functional cortex, and the whole brain is functional. So we're not going to talk about eloquent versus non-eloquent brain and get into that debate, but there certainly are areas that we deem more important for what makes us human, and certain functions we're more pressed to want to preserve. And there are limitations to mapping, whether it be asleep or awake, and those limitations are different and unique to each modality. But in general terms, there aren't effective means of mapping speech and language from a stimulation perspective in the operating room and in a sleep patient. Other modalities such as sensory inputs and vision also aren't well mapped in a sleep patient. Motor function, I think you have a little more flexibility, but that can also produce challenges both in the awake and the asleep patient. So I think a lot of these questions are patient specific, localization of the tumor or other pathology, type of pathology, whether it's a diffuse or a focal pathologic entity. I think all these play a role in terms of decision making. And you're still restricted, right? If you think about stimulation mapping in the operating room, you're talking about doing something for a few seconds at most. And what can you test in those few seconds to then detect that losing this area of the brain is going to be a problem? And that's where some other non-invasive testing, in addition to what we've talked about already, but some of the more advanced MR techniques can sometimes help us understand the connectome better, and where different pathways may converge and create a problem for the patient even before surgery. And that's not even getting into discussions of brain shift at surgery and some of the challenges that poses to us as we operate.
And so you touched upon some limitations that we as surgeons encounter when we're doing awake mapping in the operating room. Can you elaborate on that a little bit in terms of what limitations exist for certain types of mapping modalities?
Well, I think there's some practical things when you're doing awake surgery, right? So we need to make sure that the patient can be awake and alert and at the time we need them to be, and cooperative. So, but how can they be comfortable, right, through that process? And so there's many different ways people do that. Some authors describe using LMA or even full endotracheal intubation and then waking the patient after craniotomy. Others talk about conscious sedation techniques using various drugs, and we can get into the details of that too and into the weeds a little if you want. And there's different ways to do it, but the point is, how do you get the patient to an awake state, comfortable, calm, right, to then get through the case well? I mean, this is maybe a little banal, but one of the things that I do for my patients is they choose the music that is listened to in the operating room. So they feel, it's a small thing, but it's something they control completely. And some of them really take it, I have patients who bring playlists into the hospital on their own Spotify account and log in, and we just play their playlist, right? Or that their loved ones have put together for them. So that's a little thing that I do that helps calm the patient as they go into the operating room and has made a difference for them in my hands.
That's great. And since we're going to kind of talk about, awake versus asleep mapping, can you tell us just a little bit about maybe what you can test asleep versus awake, and maybe how you, kind of the differences between a sleep kind of mapping surgery versus an awake one?
Right. So I think if you look at all of neurophysiology that's used, right, there's a lot of different modalities used in the operating room setting. From an asleep perspective, you think about things like motor evoked potentials, somatosensory evoked potentials, auditory brainstem evoked responses, lower cranial nerve testing, obviously down into the spinal cord as well. We're just focused on the cranial compartment for this discussion, but more specifically, when we think of electrical stimulation, right, direct electrical stimulation, then you can start talking about details such as frequency and current thresholds and monopolar versus bipolar stimulation. And there's a lot of different methods that go together and whether it works or not. And the most common, I think, in awake setting classically has been the Ogeman bipolar stimulation technique, which is a low frequency technique with bipolar stimulation, 5 millimeters between electrodes. And there are techniques with high frequency bipolar stimulation, train of 5 techniques that several authors have published on that do appear to have a lower after discharge potential, so potentially less problems with intraoperative seizures and monopolar techniques as well. But then there are challenges with localization with these methods. In the asleep patient, I think in general terms, if you want to talk about the 30,000-foot view, maybe patients need higher levels of stimulation. They're more dependent on level of sedation. So you may need different, so your threshold won't necessarily stay the same throughout the procedure. And I think that's important to recognize, right? Just like with motor evoked potentials. And then you ask specifically about, what is reasonable for asleep versus awake. And if we talk about sensory motor mapping, language mapping, which are probably the three most common modalities we speak of, and awake mapping, really motor is the only one that we would talk about from a sleep perspective. There aren't good language mapping techniques outside of non-invasive imaging overlay and navigation that are well developed in the sleep arena. And that's certainly true for the sensory system as well. Visual system, I would add too, is really better in the awake patient, and visual evoked potentials I think are a little bit about, they tell you have a problem, they don't help you predict and avoid a problem. So I don't know many surgeons who use visual evoked potentials outside of research settings in the operating room.
Are you using motor very often with awake patients, or are you doing that typically asleep?
So with me, I do, just in my personal practice, I give patients the option of awake versus asleep if it's non-dominant cortex and I'm only concerned about motor, especially if it's a focal lesion like a metastasis, let's say, and you just need to identify your corridor of entry and then have a pretty clear, whether it's a cavernoma, let's say, or a metastasis. Then I think the asleep patient is very appropriate in the motor setting. I think if I need to do language mapping, visual mapping to try to preserve vision or sensation, then I'm always going to be doing it awake. If there's any way to do it awake in that patient. Now, if there's a patient who there's no way they can tolerate awake from a neuropsychological perspective, or you've tried and failed to do it awake, then you have to sometimes think of alternatives. And, from a glioma perspective, what I always tell my trainees is you're not debating between 0 and 100% resection. It's always 80 versus 85% resection, where 85% gives them a fixed deficit and 80% won't. And you got to find that 80%, right, for that given patient, or the 65% or the 95%, whatever, that leaves them without a new neurologic deficit, but gets maximal resection, right? So I think emphasizing the safe part of the maximal safe resection, I think, is important when you talk to patients, and why we're even having the discussion. In a sleep patient, why do you still want to map whatever you can? It's, again, an emphasis on safety and neuronal preservation, functional preservation.
So it appears that the type of lesion does play a part in addition to its location in helping you decide which modality you're going to employ. Can you talk about that a little bit more?
Yeah, so we talked about localization already, right? So dominant versus non-dominant hemisphere. There are a number of patients who have bilateral language representation as well as right-sided dominance. But that can often be teased out from either functional MRI or WADA testing before surgery. And with that sorted, then you can usually determine based on localization what your needs are. I find that diffuse lesions such as glioma, I'm more inclined to do an awake surgery simply because these tumors frequently cross and need at least an assessment of resection from eloquent areas, in either cortex. And there's some argument that you might, from my experience, this is anecdotal, but from my experience, I think a sleep mapping, at least from a motor perspective, is as safe at preservation as awake mapping, but resection might be a little better simply because our thresholds are more constant. And so we, at least in my hands, I think I do. I can't prove this. I've looked at my own series and I can't prove that my extended resection is better. It's not. It's no different from a statistical perspective. But my anecdotal perspective is that I believe I get closer because I'm confident of the threshold current necessary for whatever modality I'm using to get me, closer and closer to the lesion without going into into the eloquent area that I'm mapping without going into and through it. Whereas with the sleep, because of changing levels of sedation and different levels of current that you have to apply to get a consistent signal, I think as long as you get the signal, you can be confident. But how close can you get to the signal, I think, is somewhat debatable. Just like the value of monopolar versus bipolar stimulation in low and high frequency, I think it depends on if you're talking cortical versus subcortical mapping as well. And I think that can be challenging. And I think that's evident in the literature where, there are different modalities out there. And neurophysiology, I think, is a little, especially on the sleep side, mixed in terms of recommendations for what to use.
Yeah, I was going to ask you about that because there's always sort of, I think, with any mapping procedure, there's a little bit of a bit of uncertainty to it. I think most surgeons, we like to have control over all the variables, and sort of the key variable of the surgery, I always feel like you have a little less control than you might want, because I think, there's limitations for both types of procedures, sleep or awake, and they're different, right? That you kind of alluded to some of the awake limitations is the patient kind of participation. Now, sleep, there's limitations also. You've also alluded those are kind of more anesthetic, and any kind of pearls of how to try to maximize your chance of success.
Yeah. So I guess there's one other thing to go back before I answer that question, right? One of the other patients that may be more appropriate for an awake setting versus a sleep setting is an elderly patient or a patient with higher anesthetic risk. Sometimes doing that patient awake under local plus or minus conscious sedation is actually safer for the patient from a cardiopulmonary perspective, where we are treating older patients. The guidelines, the CNS guidelines, do recommend in patients over 70 still, if they have a decent KPS score, to have maximal safe resection. And in that setting, sometimes cardiopulmonary risk becomes an issue and makes an awake surgery more valuable in that regard too. So that being said, now you ask about what are pearls to try to optimize mapping, whether they're asleep or awake. I think in the awake patient, the most important thing is patient comfort, right? So if you can prepare the patient well beforehand for expectations, right? I think that's very helpful. And, one of the challenges that we face is, the patient with high anxiety would love to get a benzodiazepine, but you give a benzodiazepine or something like dexmedetomidine, and suddenly we're stuck with a patient who makes semantic and or phonemic errors from the sedation at baseline that they maybe didn't make without sedation. And some of these agents are relatively long lasting. So from a practical standpoint, I typically use propofol and remifentanil because they're short acting. And if keeping them on is a problem for the patient to do mapping, then maybe we have to turn them off completely, and they come off and on relatively quickly. In my local, I use not just bupivacaine and lidocaine in combination, but I add a little clonidine. And clonidine increases the length of how long your local lasts in the patient, but it also has some mild calming effects, similar to the dexmedetomidine, but is not as sedating. So, and it's given subcutaneously, so it doesn't go systemically very quickly. So I use, I can be very practical here. So I use 25 milligrams of 1% lidocaine with 100,000 parts epinephrine with 25 mLs of 0.25% plain bupivacaine. I add to that 5 milliliters of sodium bicarbonate, and then 100 micrograms of clonidine.
That's
So,
really interesting. Yeah.
and that's what I mix into, and it is my local for my regional block,
Mhm.
and the Mayfield pin block. And my blocks last, with that addition of clonidine, they'll last an hour or two longer. Consistently use about 30% less local through the course of the procedure. They have much less muscle pain, and we're often going through the temporalis to do these procedures. And you don't have quite the sedative effect. Some people use dexmedetomidine for that, either with the local or IV. And I find that this is less sedating and causes fewer semantic errors with the awake mapping cases. So I find that useful. In the asleep patient, I think level of sedation is important. So I think you need to monitor carefully patient's level of sedation. I use transcranial motor evoked potentials as well. Some people use subdural grids to do that. Instead, I just go transcranial before the procedure, and we set up electrodes, and we have that as a baseline. And we do bilateral motor evoked potentials, so that if you're not finding threshold or not finding corticospinal tract or the primary motor homunculus with stimulation on the surface or subcortically, you have a backup for a double check on the system, especially if you're using monopolar stimulation. Then it's a really good check on the system, because you're just using essentially higher thresholds transcranially. So it can be a double check for your system connected through the same EMG electrodes on the extremities. So those are some of the techniques that I use, to help make motor mapping in the asleep patient more effective, especially if you kind of lose signals and you don't know why, because maybe you haven't done much motor.
One comment I'd make is that, if I expect a lot of shift, especially if it's a big tumor, sometimes I'll put a subdural stimulator essentially so that it stays on the surface of the brain. So that's one way you can make yourself uncomfortable, is if your brain shifts away from the cranial, external kind of electrodes.
Yeah, it can, and that can be super useful. Looking for phase reversal can be useful. There are a lot of nice little adjuncts that can be helpful. There are also things like 3D navigated ultrasound that can sometimes help adjust for brain shift with navigation. So there, if it's a high-grade glioma and you're using fluorescence guidance with your navigation, that can also help understand what brain shift is happening and where things are moving, also subcortically. So yes, I think all those adjuncts are helpful. And I think the goal for all this is find what works at your institution, in your hands, in your patient, to make it as safe as possible. And I think the emphasis needs to be on safety.
In that same vein, Dr. Ormond, in your practice, which mapping modality or paradigm do you find the most useful in providing you good functional as well as oncological outcomes?
So I traditionally, in the awake setting, use standard Ogeman stimulator like modalities, right? So I use low threshold bipolar stimulation, 5 millimeters between the stimulator electrodes, and stimulate at 60 hertz between typically 1 and 6, and usually between 2 and 4 milliamps of current you get threshold. I tend to balance, there's a group of surgeons who very strongly feel you need a large craniotomy, right, in awake mapping, and get your positive thresholds on motor homunculus and speech mapping first on the cortex, and then go to the lesion. And there's another group of authors who feel very strongly that thresholds are so commonly at the same levels in an awake patient that it's also reasonable to do a smaller opening and find negative thresholds up to 10 milliamps as long as you don't get after discharge potentials and you're safe to resect with similar results. So I'm not going to get in that debate, but in my practice, I tend to be a little more in moderation, where I do make not a huge craniotomy, but I try to intentionally cross a little bit of the motor homunculus or expressive speech area, because I think patients, especially who present with mild semantic or phonemic errors at baseline, can be a little difficult to tease out sometimes if they're worse with stimulation, especially when you're looking for threshold. And so it's really nice just to have the frontal operculum exposed just slightly. Even if you otherwise just need a temporal exposure, I like that because then I can find my threshold on motor tongue or causing speech arrest, and then go from there down into my temporal lobe cortical to still find threshold. So that's just, it gives me a lot of reassurance, at least in the awake patient, without a very much larger craniotomy. So that's my typical practice.
Yeah, there are proponents. I know we're reaching our limit on time, but there are proponents for just doing a negative mapping to prove to yourself that nothing.
And that's what I've said. So you do negative mapping. If it's all negative to high, but I do think that if you stimulate up to say 10 milliamps, which is kind of the standard with the Ogeman boxes that are, they're not being made anymore, but other companies certainly still have their products. So I'm not advocating for any specific product, but the higher you stimulate, the higher your risk of intraoperative seizure events are. I mean, that's well known in the literature and has been for a long time. There's some people who even advocate for no electrocorticography as long as you only stimulate below certain thresholds and have similar, at least symptomatic, right, seizure results as surgeons who operate with electrocorticography. So I typically don't stimulate above 6 milliamps, even though I also use electrocorticography. I also use 2 anti-epileptic agents, even in patients who did not present with seizures. And I typically use, in that setting, I use levetiracetam and phosphonatoin are typically my go-to agents if there aren't allergies. And I typically use one added agent, even if they're on a baseline anti-epileptic coming into the operating room, because I do feel that direct electrical stimulation does increase seizure risk. And that's the worst thing that can happen is the patient has a seizure, can't talk, maybe they're not intubated. And now what do? It's much better for us if we can prevent that, which is why electrocorticography looking for after discharges, I think, can be very useful at preventing intraoperative, even subclinical seizure events, which can be picked up, and then we can understand why we're having some speech problems, let's say, in a given patient.
Well, that was fantastic, and thank you so much for this wonderful discussion, and to our listeners for tuning in for this podcast. Please follow us on social media at Rushna Ali 6, at Seth Oliveria, at CNS Update for upcoming podcast episodes and other educational materials. Thank you, everyone.